All right, so as part of your assessment, you know you have to do the history taking aspect of it. So you want to make sure you investigate the chief complaint, try to figure out what your mechanism of injury is, and get a history of the present illness. What's going on is what you're trying to figure out and what happened. Um, check your patient's mental status. With your chest injuries, you really want to pay attention to difficulty breathing. Chest pain, you want to find out, is it a tearing pain? Is it a sharp pain? Sharp pain is typically associated with rib fractures. Tearing pain is typically associated with your aortic injuries. Um, where are they hurting? Where's the pain at? Do they have a history of heart problems or respiratory problems that could aggravate the current injuries that they have? Do they have their seatbelt on? And that's important for two reasons. If they wear their seatbelt, the injuries to the chest will be substantially less, but you also have to worry about injuries from the seatbelt. And we see some aortic injuries in our really high speed collisions when the patients have their seatbelt on. Um, if the patient doesn't have their seatbelt on, as far as the chest is concerned, the chest goes into the steering wheel. You get pulmonary and cardiac contusions, which will compromise blood flow and respiration. And you want to pay attention to what kind of medications they're on. Beta blockers mask the signs of shock. Blood thinners will, you know, patient will bleed to death. Blood won't be able to clot. They take things like warfarin or Coumadin and blood thinners. So you really want to pay attention to, what's their medications if you can. And in a lot of these situations, the patient don't have their medicine. They can't tell you what they are. But the more information you have, the better prepared you can be for the consequences of those injuries. So, what are associated signs and symptoms? Do we have any pertinent negatives? If the palpation of the chest causes direct pain, then we start really leaning towards musculoskeletal versus a cardiac or an organ issue. Verify where the pain was located in relationship to the area being touched. Um, and a lot of times, if you have like a multiple rib fractures, you'll palpate one rib and they'll have pain in a large area of the chest. Do they have shortness of breath? Do they have rapid breathing? Do they have absent breath sounds? Do they have deformity or abnormal movement? If they have those things, that lets you know that they're really in distress. If they don't, you really want to kind of take a step back and start doing some further investigation to try to figure out what's going on. Get your sample history. Uh, Complete a basic evaluation of symptoms, allergies, medicine, past pertinent medical problems. Respiratory or cardiovascular disease is important with chest injuries, and when their last oral intake was. And then you want to get the events leading up to the emergency. What were they doing? What was going on? And then what happened are the most important things that you're going to be asking. So for your secondary assessment, look for injuries with the potential to compromise airway, breathing, circulation. And if we find those in our secondary assessment, we want to make sure we fix them. In case of isolated injuries, focus on that injury. Uh, somebody gets hit in the chest with a uh, baseball bat or something. That's going to pretty much be isolated to that area of focus. Um, Look for ecchymosis or other evidence of trauma while assessing the skin. Ecchymosis or redness, like somebody punches you in the chest, you get a red mark before it bruises. Those let you know that there was some energy that was transferred or transformed in that area, and there could be some underlying injuries to the organs that you can't see. Do the full body scan. Look for DCAT, BTLS, deformities, contusions, abrasions, punctures, penetrations, burn tenderness, lacerations, swelling. Get a full set of vital signs and make sure you're trending your vital signs. Your chest injuries, you should be trending every 5 minutes. And use the diagnostic tools to evaluate the respiratory system. Use your pulse oximetry. And we've talked about the limitations of pulse oximetry before. If you're running out of blood, you don't have enough blood flow, it's going to show high, but you don't have enough hemoglobin to saturate. So keep those things in mind, as you're evaluating the patient. For reassessment, you want to make sure you're trending those vital signs every 5 minutes. Make sure they're oxygenating. Reassess your breath sounds. Always reassess the chief complaint. See if that's changed. The chief complaint is very subjective, which means the patient tells you what it is, and oftentimes that'll change. Um, and make sure you document. If you don't document it didn't happen, I'll say they use your trauma documentation to make changes to the trauma care system. And here recently, just in the past 6 or 7 years, we've completely changed the way we're treating trauma patients based on patient outcomes, and we've been able to track that through EMS documentation. So, stabilize your airway, breathing, circulation, uh, manage the patient's airway, respiratory status, maintain C-spine if you need to, uh, provide oxygenation, be a non-rebreather for adequately breathing patients or a bag valve mask for inadequately breathing patients. Um, do not increase the patient's work of breathing. Whatever you do, take the pressure off the patient for breathing. So if you have to ventilate them because they're struggling, go ahead and ventilate them. If they're struggling, make sure they're on high flow oxygen so they don't struggle as hard. That increases energy demands and makes shock worse. And treat for shock. Lay them flat, high flow oxygen, and make sure you keep them warm. We've talked about what hypothermia does to blood clotting and those other things. So make sure you're keeping those patients warm. Get IV access. You want to establish, this says at least one, we're establishing 2 large bore IVs, and we give 20 milliliter per kilogram fluid boluses. And what we do is we give them in about 500 cc increments, and then we reassess. You want the systolic blood pressure to stay between 80 and 90. That's called permissive hypotension. And we talked about in other chapters, running the blood pressure up too high will dilute the blood and blow those clots out. So by maintaining a blood pressure of 90 to 100, we're maintaining a blood pressure that's just adequate enough for perfusion, while we're trying not to blow those clots out or dilute the blood. Rib fractures, these are very common. The most common chest injury you'll see is a rib fracture. The upper 4 ribs are well protected by the bony girdle of the clavicle and scapula. So your shoulder blade and your collarbone really protect those upper ribs. We see a lot of rib fractures, 4 or 5 in that area, over to the sides of the chest. Morbidity and mortality rates from rib fractures can be severe. There's nothing that you can really do for minor rib fractures. Where you have issues is when you have major large areas of ribs that are fractured and the chest is unable to expand and you're unable to oxygenate. Evaluate your mechanism of injury and keep in mind that if there's a force strong enough to fracture ribs, then those underlying organs are probably going to be injured as well. A fractured rib may lacerate the lung. You may see subcutaneous emphysema, which is those Rice Krispies that air up under the skin. And make sure you relay this finding to the hospital so they can be prepared. Rib fractures are typically caused by blunt trauma. However, bullets, a knife in the right spot with enough force can cause rib fractures, but most oftentimes we see our rib fractures with our blunt trauma. Atelectasis decreases the surface area for gas exchange, and this is where your lung just collapses. The alveoli don't expand. The result is a ventilation perfusion mismatch. We talked about that. That's where you can't get oxygen to the blood or you can't get blood to the oxygen. In this case, it would be unable to get the oxygen to the blood. You may have hypoxemia, which causes brain death and acidosis. Severe trauma to the first and second rib may result in a ruptured aorta. Your aortic arch is up there around your second your second rib. Ruptured aorta typically does not have a good tracheobronchial tree injury. This is where those airways are just ruptured, and then vascular injury is where you have the vasculature. You begin to bleed internally, and the veins and arteries around the rib cage, they run on the lower side of the rib, and on top of the rib there's not really anything there. So when we do chest needle decompressions and things like that, we always aim for the top of the rib. So with a posterior fracture, and this will be the back side of the rib cage, we see the 5th through the 9th ribs most often fractured on the posterior side of the body. The floating ribs are pretty well protected, not really fractured. If you have rib fractures, those bone fragments leave you susceptible to any of your organs being lacerated. The energy leaves you susceptible to cardiac and pulmonary contusions, sheared aortas, ruptured diaphragm. So how do we manage our rib fractures? First, we want to manage airway, breathing, circulation. Okay, and the big thing is going to be airway because we're going to have a compromised airway. Sometimes the patient can put a pillow there and hold it, and a lot of times that'll help them with the pain and help them breathe deep at the rib cage. So you have a free floating segment. This is trauma. Um, I've actually seen it in an older lady. She fell and caught her chest on a heater in her nursing home room and broke a couple of her ribs, and you could actually see the flail segment. Others I've seen with massive chest injuries from motor vehicle accidents. The worse the flail segment, the higher the mortality rate. So the bigger that segment is, those people die. It can cause hemothorax, pneumothorax. Chest should be exposed and examined for DCAP BTLS. A flail chest is managed by positive pressure ventilation with a bag valve mask. So if your patient's breathing inadequately, we want to make sure we're adequately inflating those lungs with positive pressure. Blunt force trauma that causes a flail segment can produce a pulmonary contusion, so you may have a VQ mismatch because of that. But remember, your treatment for flail chest is positive pressure ventilations. Sternal fracture, this comes from high energy impact trauma to the chest. And it is blunt trauma. Um, this high level of energy can injure all of those internal organs. It can cause aortic shearing, cardiac contusions, pulmonary contusions. You may see flail chest. Typically, these patients have hit the steering wheel very, very, very hard or been hitting the chest very hard to fracture the sternum. You'll have localized pain and tenderness over the sternum with crepitus on palpation. And tachypnea is a common finding because that sternum won't let the chest expand and relax like it's supposed to. We see a lot of clavicle fractures. See these in children with falls, older people with falls, people fell off ladders, side impact injuries. These will cause your clavicle to fracture. I see a lot of clavicle fractures in rollovers. They'll report shoulder pain and won't be able to have range of motion of their shoulder. It's usually in the front, and I've seen clavicles that have been fractured where you can actually see the bone grinding through that thin piece of skin. The way we handle clavicle fractures is the same way we splint shoulder injuries. We use a sling and swath with our triangular bandage, and we make a sling with one bandage, and we take a swath and we secure the arm to the patient's body with the other bandage. Works really well. And then we'll get the patient to self-stabilize while we move them, if that's possible, from the stretcher to the hospital bed and those kind of things. Remember, in your multi-system trauma, we're not going to splint, okay? We're going to use the spine board as a full body splint. We're not going to splint our patients to death. But in that isolated trauma where you're able to splint, we use a sling and swath for our clavicle fractures. Comatocortis. This happens when the heart is basically stopped because of a hard impact to the chest. Baseball bat, baseball. Sometimes in football, the patient gets hit hard enough to make their heart stop. But what happens is that sudden impact transfers energy into the heart, which jolts the electrical system and causes ventricular fibrillation. These patients will be pulseless. They will be apneic, which means they have no pulse, they're not breathing. You will need to immediately start CPR, and the treatment is defibrillation with an automated external defibrillator, or AED. The faster they get defibrillated, the greater their chances are of survival. We treat these patients by ACLS protocol, just like we do someone in cardiac arrest, even though the injury is from traumatic injury to the chest. You're probably going to see that again, so make sure you remember what comatocortis is. And the next couple of things, the pneumothorax, as we talk about the simple, the tension, and the open, you will absolutely need to know the difference in and the treatment for. So a simple pneumothorax, if you'll look at this lung, you notice how it's fully expanded. And then you notice how this lung has shrunk down. What's happening is somewhere there's a hole. Say there's a little hole right there. and air is leaking out of that lung. And the more air that leaks out, the more that lung is pushed inward. Okay? This lung is not participating in gas exchange. And now remember, you got your heart right there. So the more this lung moves over, the more pressure it puts on the heart. But a simple tension or a simple pneumothorax is shortness of breath, probably some chest pain, oxygen saturations above 94, 95%. Okay? The treatment for a simple pneumothorax is high flow oxygen. Okay? Amount of pneumothorax that develops varies. Spontaneous pneumothorax is possible in patients who experience sharp chest pain. Typically see it in our tall, thin people, and it's usually brought on by a hard cough or lifting something heavy. And what happens is the lungs, the alveoli get a little weak spot or bleb on them, and they pick up something or they cough real hard, and that bleb pops, causing a pneumothorax. They'll be a little short of breath, maybe a little tachycardic, and what we do for our simples is we put them on a non-rebreather and give them high flow oxygen. Okay? Chest wall movement decreases as pressure increases. Hyperresonance on percussion. Diminished breath sounds is your telltale sign. Okay? So when you auscultate breath sounds, if they have diminished or absent breath sounds, now you're talking pneumothorax. Do your percussion, and that'll tell you hyporesonance, pneumo versus hemo. Immediately cover any wounds with an occlusive dressing taped on 3 sides. Repeat assessment, call for ALS backup because the patient may have cardiac dysrhythmias and they may develop a tension pneumothorax, which will require a chest needle decompression. So an open pneumothorax, this is your sucking chest wounds. This is when you get hit with some penetrating trauma and the outside air is open to the inside air. And what happens is that causes the outside air to come in and surround the lung and create an external pneumothorax with air from the outside. So you don't have that negative pressure you need for inhalation. The pressure causes the lung to begin to collapse. The patient will have hypoventilation and hypoxia. You may start seeing the jugular veins slightly distend with the simple. When you move to a tension, that's when you really start having those hemodynamic compromises, and you'll have hypoxia because you lose that surface area for gas exchange. Air enters the pleural space during the inspiratory phase, and the negative pressure is what sucks that air in through the hole. Once it gets in, it's unable to escape. You can also have direct lung tissue injury or injury to the parenchyma, and that's from that penetrating trauma that went in and actually made the primary injury tissue damage. The vena cava can become occluded because of the moving of the mediastinum as the pressure builds up. So basically you build up pressure and you kink that water hose. If you kink the vena cava, your patient will immediately die because they'll have no preload. So just keep in mind that preload will begin to become decreased and your blood pressure will become decreased because of the pressure on that vena cava and because of the pressure on the heart. So note the presence of a defect in chest wall or penetrating injury. This is an open pneumo. There's the little arrows that show how the air goes in and out. We've talked about it. It's called a sucking chest wound. Tachycardia, tachypnea, and increasing level of distress. Okay, we have done is we've created a pneumothorax where external air is pushing against the lung. To treat a sucking chest wound, you treat it immediately. First, you put a gloved hand over the injury. Okay, once you put the gloved hand over the injury, you want to place an occlusive dressing or a chest seal. These typically have a flutter valve that will release air as it builds up. If not, you're going to have to get a paramedic to do a chest needle decompression. So you want to make sure you document what type of material used. Did you tape 3 sides or 4 sides? If there's not a flutter valve, tape 3 sides so you can make one. If there is a flutter valve, secure it to the wound. You want to note changes in skin color, vital signs, changes, breath sounds, the same trending stuff you do for every other patient. If the patient begins having trouble breathing, make sure you burp that dressing or lift that corner up to allow the air inside the chest cavity to escape. Tension pneumothorax, this one's bad. You notice this lung is completely expanded. This lung is almost completely pushed over under the sternum. Everything is shifting away from that pneumo. The heart is being compressed and unable to beat. The difference in a tension and a simple pneumothorax is hemodynamic changes. The patient becomes, their vital signs begin to become unstable. Okay, you will have absent breath sounds on the affected side, no breath sounds, hyperresonance where that air is, okay, unequal chest rise, pulsus paradoxus or an absence of pulse on inhalation, tachycardia, and this pressure on the heart can cause cardiac dysrhythmias. Increasing pressure within the thoracic cage leads to the accumulation of blood within the great vessels outside of the thoracic cage. So what we're doing is we're shutting preload down. We begin to drop that blood pressure. They'll have pleuritic chest pain, shortness of breath. A normal blood pressure suggests when other signs of attention pneumothorax are present. Um, if you have a normal blood pressure and you have all the other signs of attention pneumothorax, that just means the vessels have not been compressed yet. Your job as an EMT is to manage airway, breathing, circulation, high flow oxygen, and call for ALS backup. Okay? Inspect the chest, as always, with every other patient. Cover any open wounds with an occlusive dressing. We've talked about that. If signs of a developing tension are present, lift one corner of those dressings to allow the air to escape. If it's a closed tension pneumothorax, you're going to need a paramedic to do a chest needle decompression and release that air, internally with a large needle. Hemothorax, this is blood. You see here's your lung here, and then you've got all of this is blood. If you've got that much blood in your chest, your patient's probably dead. Typically, this is what you see when you put a chest tube in. This patient would be in advanced stages of shock with that much blood in the chest. But the parietal and visceral pleura become compromised or violated, and it begins to bleed and blood starts to accumulate in the chest. That's hemothorax. Tears in the lung tissue, tears of the pulmonary capillaries, tears of the arteries and veins in the chest. Any penetrating wound that punctures the heart or vessels within the chest will cause a hemothorax. Blunt trauma, which is steering wheel, baseball bat, that can cause a shearing of those major vessels or even the small vessels, and they will begin to bleed. They'll shear, they'll rip away from their connecting points and begin to bleed. We see rib fractures that get into the lung paramentia and violate that tissue, and that paramentia starts to bleed. Hemothoraxes are a life-threatening injury. Your patient will suffocate or bleed to death, whichever one happens first. A massive hemothorax is accumulation of more than 1,500 cc's of blood. As blood accumulates, the lung collapses, basically puts pressure and weight on that lung, and it keeps it from contacting the pulmonary capillaries, so you have no gas exchange. Depending on how much blood is in the pleural space depends on how bad it's going to be, how much hypoxia you'll have, and it'll also tell you, how big of a drop in blood pressure to expect. Hypotension and inadequate perfusion. This says may result, but it is expected from any massive hemothorax. The patient's going to have signs and symptoms of shock. Decreased breath sounds on that side would lead you to believe it's a hemothorax. Remember your percussion and pay attention to the jugular veins. Flat jugular veins are indications of shock or bleeding. Distended jugular veins are indications of blood loss. So if you have diminished breath sounds with flat jugular veins, in your brain you need to start leaning towards hemothorax. Hemopneumothorax, that's a combination of both. That's blood and air in the chest. The findings are the same as a hemothorax. Most of your hemothoraxes are hemopneumos. Administer high flow oxygen, positive pressure ventilation is needed. And if the patient becomes hypovolemic or they get a drop in blood pressure, give your fluid boluses to maintain that blood pressure between 80 and 90. Remember your passive hypotension. Pulmonary contusion, this is a bruise to the lung. It's the most common injury from blunt trauma. We see this in patients with flail chest, high energy impacts to the ribs. You really want to watch your mechanism of injury and keep in mind that the patient may have a pulmonary contusion. Big issue with pulmonary contusion is the loss of space for gas exchange between the alveoli and the pulmonary capillaries. Um, Mechanisms are implosion effect or overexpansion of air in the lungs, secondary to pressure waves caused by blunt trauma. That just causes the lungs to bruise from that energy transformation. Inertial effect strips the alveoli from the heavier bronchial structures, just makes them heavy. And you think of inertia being weight or mass, and so that inertia will weigh those alveoli down. And then the Spalding effect is where you have a liquid interface such as blood, um, you know, disrupted by a shock wave. You get some bleeding in there, you get some liquid in there. Your interstitial fluid begins to move, your intervascular fluid moves, and disrupts your perfusion. Alveolar and capillary damage from these mechanisms cause interstitial and intraalveolar hemorrhage, fills them up with blood, no gas exchange where the blood's at. For large contusions, the body may cause vasoconstriction, um, increasing pulmonary blood flow, and increasing cardiac output. This can actually make the contusion worse in some cases. Pulmonary shunting decreases functional reserve capacity and leads to mixed venous blood being returned to the heart, so your blood will not be as saturated as it would be, absence the cardiac contusion. Auscultation, you may hear wheezing, rhonchi, rales, or diminished breath sounds, and this is just from the swelling and the fluid buildup in those airways. You would give supportive treatment, provide oxygenation, ventilation, rapidly transport them to the hospital. Um, Keep your systolic blood pressure between 80 and 90 and limit your IV fluid boluses if you need to. That you can actually cause fluid overload and additional swelling from those IV fluid boluses. Here's your pericardial or cardiac tamponade, and what happens is there's a little thin layer. It's almost like saran wrap that surrounds the heart, kind of like a Ziploc bag, and it holds real tight to the heart. And what happens is you get like an ice pick to the heart. Okay, ice pick comes out. This fibrous sac seals up. So ice pack went in, the sac sealed up. So now you've got a closed sac that is filling up with blood because we punctured our heart. So blood begins to leak out into the sac or around the heart, and it can't escape because our hole closed up. So now, every time your heart beats, you're bleeding in this sac. You see here how your heart's full, fills the whole sac, and here how the heart is shrinking? What's happening is this is putting pressure on the heart, causing that muscle to shrink and draw up. Well, Frank Starling's law says the heart has to expand like a rubber band in order to contract. So the more pressure you get on this heart, the less likely it's going to be to contract. So the pericardium attaches the great vessels at the base of the heart. There's two layers. There's the visceral that lays on top of the heart, and then there's the parietal that lays over the visceral pericardium. And the pericardium anchors the heart, prevents kinking of the blood vessels. It can hold about 30 to 50 milliliters of fluid before you start seeing any signs or symptoms of a pericardial tamponade. Accumulation of fluid over minutes leads to intrapericardial pressure, kind of like filling a plastic bag with air. The more air or water you put in it, the higher the pressure is going to be. Puts pressure around the heart and reduces cardiac output. May result in a myocardial infarction because the pressure on the myocardial circulation becomes impaired from the outside pressure on those blood vessels. If you can remove 20 milliliters of that blood, cardiac output will be improved dramatically. The problem is we do not do that in the field. That takes someone in an emergency room doing it under ultrasound. And the treatment is a pericardial centesis. They take a big long needle, poke a hole in the sac, and draw the blood out. We see this in medical and trauma patients. Our medical patients, our transmural myocardial infarctions, our cancer patients, and we see it in trauma patients. It takes a severe amount of blunt trauma to do it. So your most likely cause and almost your exclusive cause is going to be penetrating trauma, but in very rare circumstances, blunt trauma can cause a cardiac tamponade. Manage your ABCs. 2 large bore IVs. The problem with a tamponade is preload. So we want to fill up the tank. If their blood pressure is dropping, get it below 80 or so. You want to make sure you give your 20 cc per kilogram fluid boluses and maintain that blood pressure between 80 and 90. The definitive treatment is a pericardial centesis. Myocardial contusion is a bruising of the heart muscle. You get heart and blood vessel damage from that bruising. You get a fibrous reaction at the contusion site, which is kind of like a blood clot that starts to form. That can cause a ventricular aneurysm. That clot can break apart, and the ventricle can actually start to bleed in the pericardial sac. You may have right or left-sided heart failure, so you want to check for rales in your lung fields for left side, and swelling in the ankles or other parts of the body for your right side. And depending on how bad it is, depending on what your clinical signs may be, patients will present with retrosternal pain or pain right behind the sternum, or they may not show any external pain. They may have crackles or rales on auscultation, and you want to give supportive care. You always want to start at least one large bore IV. We always say start 2 large bore IVs, give them high flow oxygen, and frequently check their vital signs for decompensation. You want to treat these patients very aggressively, and look for your jugular vein distension with pulmonary edema. Okay, as the jugular veins distend, that lets you know there's increased pressure in the chest, and that pulmonary edema lets you know that you have fluid backing up from the myocardial compromise. What if your heart ruptures? Probably going to die. The ventricles, the atria, the septum, the chordinae, tendonae, that controls your valves. Really hardcore blunt trauma to the chest will cause valvular disruptions, and you'll start having blood back up from the ventricles to the atria because the valves can't close. The papillary muscles that hold the heart in place, they can get ruptured, pull apart, heart starts to swing erratically, and you can actually have valvular injury to the valve itself. And we see that with your semilunar and your aortic valves and your pulmonary valve. And just know that these injuries to the heart typically result in death. But we really do supportive care, 2 large bore IVs, high flow oxygen. Will help alleviate these injuries. Heart gets pressed between the sternum is another mechanism. They'll have acute pulmonary edema. They may have a cardiac tamponade, and we're going to do supportive care and rapidly transport them to the hospital. Aortic disruption is where an aortic aneurysm bursts on like the medical side, but it can happen from a shearing or tearing injury or severe blunt trauma. Typically, these patients don't survive if the aorta ruptures. Your aorta has 3 layers: the intima, the media, and the adventitia, and they'll become separated, and the patient will begin to have a dissection. You'll have retrosternal or intrascapular pain. It'll be a tearing pain, difficulty breathing, dysphagia, difficulty talking, hoarseness or stridor, ischemic pain to the extremities, and you may even have unequal pulses in the extremities. That's a big sign of an aortic compromise is unequal pulses, say in the right and the left hand. You may have upper extremity hypertension with absent or decreased femoral pulses. You may have a systolic murmur, and that's just a abnormal heart sound outside of that normal lub-dub. Penetrating wound to the greater vessels, these patients typically don't do well. The vena cava, that directly feeds the heart. Those are large blood vessels that can dump your whole blood volume in just a matter of minutes or seconds. The pulmonary arteries, you need those for blood return to the heart. If the artery don't take blood to the lungs, it don't come back through the pulmonary vein. So you're going to have left-sided preload reduction, which is going to cause decreased cardiac output and shock. And then you have the aorta at its branches. The carotid, the femoral arteries branch off of that aorta, and if you tear those, you're going to have massive internal bleeding, and everything below that point that feeds off of that artery is not going to be able to get blood. So wounds to any of these may be accompanied by massive hemothorax, hypovolemic shock, cardiac tamponade, and enlarging hematomas. Hematomas cause compression as that blood fills up that area. You get pressure on whatever organs are there. Your job is to get them to the hospital. They need a surgeon. The treatment for trauma is surgery. Manage your airway, breathing, circulation. Keep that blood pressure adequate, and really get them to a hospital. but the actual healing is initiated by the body. We see this with high pressure compression or penetrating injuries to the diaphragmatic area, and depending on the type of the injury, you can have intra-abdominal pressure. Abdominal contents will move into that diaphragm, that hole in the diaphragm, and the diaphragm is a muscle, so it's going to contract around that hole, and you can have bowel ischemia and actually kill your internal organs. Restricted lung expansion because you don't have as much room in the chest. Mediastinal shift, respiratory compromise. The injury is separated into three phases: acute, latent, and obstructive, and that's just kind of how the injury progresses from a sudden to, as it gets worse, as it moves on, it becomes an obstructive injury. Signs and symptoms: you have tachypnea, tachycardia, respiratory distress, dull percussion over the lung fields, lower lung fields typically. You'll have scaphoiding abdomen, which is where your abdomen changes shape like a boat. Instead of being nice and round, it'll become elongated. Bowel sounds in the chest. That's always means, or typically means you've got some abdominal organs in the chest. Decreased breath sounds, and all we do for these supportive care: rapid transport, maintain airway, breathing, circulation, aggressive airway management. Go to your positive pressure ventilation early on these patients. Esophageal injury, typically we see this from penetrating trauma, and this is just where the esophagus gets ruptured or torn. We see spontaneous perforations or spontaneous bleeding in cancer patients, alcoholics, with high or with liver issues, if they have violent vomiting, if they have anatomic distortions or diverticulitis or gastric reflux, those will erode the esophagus, and we'll see those ruptures or tears there. The patient will have pain, hoarseness, difficulty swallowing or speaking, respiratory distress, shock. You'll have local tenderness over the area of the esophagus that's broke or perforated. You may have some subcutaneous emphysema, and you may not have good range of motion of the neck for your esophageal injuries. So if perforation is intrathoracic, which means in the chest, you may have mediastinal emphysema, which is air that gets under the mediastinum. Mediastinitis, which is infection around the mediastinum. Subcutaneous emphysema, that's your Rice Krispies that we talked about under the skin, the little air bubbles. Mediastinal crunch, which is just air around the mediastinum, gives a weird sound. And the patient will be splinting their chest wall. They'll be trying to hold it. For some reason, holding it makes it feel better for them. We're going to manage the symptoms, manage airway, breathing, circulation, and rapidly transport them to the hospital. Tracheobronchial injuries, this is a result of blunt or penetrating trauma, and part of the tracheal tree is torn apart from its normal pathway, so there's basically a hole in your trachea. These have a high mortality rate because they're difficult to manage. It's hard to get an intubation tube far enough in to manage that injury. Sites of the injury is often close to the point of attachment. So where your bronchioles and your alveoli meet, or not your alveoli, well, your alveoli, your tracheal, your bronchi, your bronchioles, where they meet, that energy will tear or break those joints. Injury to the trachea or main stem bronchi allows rapid movement of air into the pleural space. So you may have a pneumothorax. It's not really a pneumothorax, but it's from the bronchiobrachial injury. And what we're going to do is we'd actually decompress that as a paramedic. Your job as an EMT is supportive care and get them to a hospital. They need a chest tube and a surgeon call for your ALS backup. What you're going to find is tachypnea, tachycardia, subcutaneous emphysema, and it's really more prevalent with your tracheobronchial injuries. You'll have a lot of subcutaneous emphysema because there's a lot of air leaving that bronchial tree. Respiratory distress, difficulty breathing, coughing blood, signs of a pneumothorax that do not respond to needle decompression. Typically, we're going to decompress these patients just because we don't know the difference. But the chest needle decompression is not going to work because remember, the visceral pleura that covers those lungs kind of separates it from the bronchial tree, and the patient may present hoarseness. Traumatic asphyxia. The best way I can correlate this is that's where the chest slams into the steering wheel when the heart's full of blood, and it forces all the blood out of the heart into the upper vessels, mainly into the head and face. This is a compression injury. produces rapid increase in intrathoracic pressure. Have never seen one of these patients live. High mortality. 99% of the time they're going to be dead when you get there. The sudden compressional force squeezes the chest, and blood backs up into the head and neck, causing jugular vein distension, engorged, and capillary ruptures. These patients will be purple from the chest up, and you know, I've seen it so severe that their eyeballs have been bulging and popping out of their head, and even seen blood coming from the ears and the nose. It's been so rough. And this is traumatic asphyxia. You see the swelling of the face, the red discoloration. Typically the eyes are going to be swollen. And you know, we call this a cardiac collar. And that means just something has went wrong with the heart. You see that redness and stuff all the way up. That means you've had traumatic asphyxia. Hypotension occurs when the pressure is released. Usually these patients are dead. But if they're still alive, when you roll the dash or pry the steering wheel off, they're going to get extremely hypotensive. You have to rapidly transport these patients to the hospital, treat your symptoms, take C-spine, obtain IV access with 2 large bore IVs, and maintain perfusion. The treatment for traumatic asphyxia is to increase preload.